Good morning, folks. I think we're going to get started. If everyone could start to take their seats, we'll start in about 2 minutes. Thanks so much. Great. Good morning, everyone, and thank you so much for joining us this morning. My name is Patrick Tigue, and I am the Health Insurance Commissioner at the State of Rhode Island Office of the Health Insurance Commissioner. I'm really pleased on behalf of the Rhode Island Healthcare Cost Trends Steering Committee to welcome you all today to this year's Rhode Island Healthcare Cost Trends Public Forum. Before we begin formally with today's agenda, I just wanted to cover a couple of items, and then we'll get right into it. First, I want to acknowledge both the Peterson Center on Healthcare, the Peterson Millbank Program, and the Rhode Island Foundation for providing support for the work of the Rhode Island Healthcare Cost Trend Steering Committee. Thank you. And then I want to briefly provide an overview of today's meeting. Today, we're going to have a range of panels that I think are going to thoroughly discuss some of the really, I think, exciting developments in driving healthcare affordability and cost containment here in the state. And those, we will start off with a panel focused on employer and consumer perspectives on affordability and healthcare cost trends, then move to a panel where we'll discuss the state's 2020 performance against the healthcare cost growth target, and finally close with a really robust discussion of the state's efforts to advance value-based payment here in the state. And so with that, I'm really pleased to say that we have today joining us Governor Dan McKee to give our opening remarks. Governor McKee, thank you so much for being here this morning.
Patrick. Thank you, Patrick, and it's great to be here on an issue that is certainly going to be a driving force in terms of Rhode Island and where we're going to go from here. The Rhode Island Healthcare Cost Trends Public Forum, that Patrick's put together here, and we're very happy and very pleased. I certainly am, as an incoming governor, the way that I came into office, transitioning in, to have good people like Patrick involved and advocating on behalf of everyone in this room to find these important, solutions to a complicated issue, far more complicated than I fully understand. So I'm looking forward to listening and working with each and every one of you in the room here to talk about the healthcare cost, as they tend to grow faster than our economy. It's consuming a significant and increasing proportion of household income. We know that to be true. Business revenue and state and municipal budgets are all impacted by healthcare cost. As a small business owner, I know that it impacted our operations every year. And that's why it's so important that you're spending the time here today to really go over issues that hopefully we can contain the cost in a way that that Rhode Island can move forward. I was one of the things that was able to do was contact with Dr. Jha early on in my transition, talking about vaccinations. We were slow in the vaccinations, but with Dr. Jha and of course the Department of Health and others, and people in this room, we were able to get to the point to be like #1 in the country on vaccinations, which is really putting us in a spot where our economy is opening quicker than anywhere in the Northeast. And that gives us this ability to have these discussions, because long term, Rhode Island has been really resilient, but it's filled with opportunity right now. And this is one of those opportunities. But one of the things that Dr. Jha said, I was at a child mental health forum with Dr. Jha, and he was asked by people that were participating, when are we going back to 2019? And Dr. Jha hesitated a minute, and he said, we're never going back there. So when you go through a pandemic or a world event, whether it's a world war or a Great Depression, you never go back to where you were. And for Rhode Island, this gives us an opportunity to go back and land in a better spot than we were. It's our choice if we do. So we know that Rhode Island worker contributions to employer-sponsored insurance premiums have grown nearly 3 times faster than the personal income since 2001. It's important that we manage these costs to ensure that health care is affordable and accessible. More affordable health care is not only better for our residents, but it makes Rhode Island a more regionally competitive place to do business. And I think part of that is in terms of reimbursement rates. We really got to look at where we are. One of the goals that we've had since I've been the governor is to level playing fields between our bordering states, between Massachusetts and Connecticut, to make sure that we land into a spot where we're competitive. So that was one of the reasons why in this year's budget, and Patrick convinced me to do it. I got good people convinced me to do a lot of things. I got Kim Hayher in here as well, one of our Deputy Chief of Staff. We've proposed $500,000 to fund the Health Spending Accountability and Transparency Program. And we think that that's really important because we need, I happen to like plans. I like to make sure that plans are well documented, and that becomes this roadmap that we can use. So I'm looking forward to the work that Patrick's going to be a lead with others in this room and around the state about really finding, using those dollars in a way that we can provide a plan and a roadmap for us, in terms of health care. The program will motivate the actions of private healthcare entities by providing transparency around what drives costs. It also provide actionable data for the executive branch and the General Assembly to make policies and pass legislation that addresses the causes of excessive healthcare spending and the growth of that cost. The program will serve as a foundation on which to build a system of shared accountability for healthcare costs across government, insurers, and providers. Over the past 2 years, our state has dealt with an unprecedented public health emergency. The state of emergency was real. It preceded me becoming governor. This emergency has had a profound effect on all Rhode Islanders, in our economy and especially our healthcare system. And it's certainly a moment to be thanking all our healthcare providers and everyone that has been working in the healthcare system, as they've been stressed to degrees that we've never seen before in our lifetime. This described that this state of emergency in the state of Rhode Island we haven't seen that since the Great Depression or even the Civil War. That's what we've gone through. That's what we've been able to walk through. So that's why, more than ever, it's important to take meaningful action to improve healthcare affordability and ensure a high-performing, sustainable healthcare system to serve Rhode Islanders. I think we share that common goal, and I look forward to listen to today's discussion and also working with you going forward as out of the governor's office. Thank you so much for having me here today.
Thank you so much, Governor McKee, for those opening remarks. So at this time, I'd like to invite up January Angeles of Baylett Health, who will be moderating our next panel focused on employer and consumer perspectives on healthcare cost trends and affordability. So if I could also ask the members of the panel, Al Charbonneau, Sam Selganic, and David Katzniff to please join us as well. Thanks so much.
I have a problem with these podiums. I don't quite get tall. I'm not quite tall enough to be seen over them. All right, good morning. It is nice to be here today. I've been telling many people this is my first in-person meeting in 2 years. So it is nice to see everybody's lovely faces. My name is January Angeles, and I am a senior consultant with Baylett Health, and I've been working closely with OHIC on the Cost Trends Project, and I have the honor and pleasure of moderating this panel on affordability. As someone who works in healthcare policy, I think about healthcare costs almost on a daily basis. I look at data on medical costs. I see trends in healthcare spending. I work on strategies to deliver care more effectively and more efficiently. And in doing this work, I hear a lot from providers, from health systems, from payers about the many challenges that they face, particularly with the current economic situation, and how it's impacting their ability to deliver services, as well as the things, the actions, the initiatives that they're taking to try and address these challenges. But it's not often that I get to hear from consumers and employers about how healthcare costs are impacting them. Right? When they see premiums go up and cost sharing go up, what choices are they faced with? So I am really glad that we have this panel to talk about employer and consumer perspectives on healthcare affordability and the importance of controlling cost trends. And personally, I can't think of anyone better to represent those perspectives than our three panelists up here, David Katzeff, Sam Salganik, and Al Charbonneau. So I'm going to ask each of you, Sam, David, and Al, if you could just introduce yourselves and talk a little bit about the work that you do and how that has shaped the perspective that you bring to the conversation that we're going to have today on affordability. And then we're going to launch into our discussion. So maybe we can kind of just go from outside in, starting with Al.
Good morning. I just want you to know that I brought my little safety valve here. My name's Al Charbonneau. I'm Executive Director of the Rhode Island Business Group on Health. Before that, I was a 40-year or so hospital CEO. I'm a native Rhode Island, I want you to know that, but I did work in upstate New York for almost 35 years. I guess you would characterize me as totally addicted to the idea of reforming healthcare.
David?
Yes, I'm David Katzeff. I'm president of a small company called Mastercast Limited. We're based in Pawtucket, Rhode Island. We only have 9 employees, but for the last 30 plus years, I've always prided ourselves in being able to offer a company-sponsored healthcare plan that our employees can participate in. And in 2014, our company was a charter member when HealthSource Rhode Island first started introducing healthcare plans for small businesses called the Shop Exchange. And I joined the Shop Exchange mainly for 2 reasons. Number one, to afford my small number of employees with choice of healthcare plans that they can choose themselves. We base our 50% subsidy on the base plan that we choose every year, and then our employees can choose a lesser plan or a more vibrant plan. The second reason was to help the affordability. I think that reason still has work to do, and I think some of the issues we talk about today are going to talk about what still has to be done on the affordability issue for commercial healthcare insurance for companies like mine who don't have the buying power to go to the insurance carriers. Hopefully through Shop Exchange, we'll be able to do better in the future. Thank you.
And my name is Sam Salganik. I'm the Executive Director of the Rhode Island Parent Information Network, or RIPEN. And I guess in some ways I wear 2 hats here. As the Executive Director of a nonprofit with just over 100 employees, we are purchasers of health insurance like other employers, and we see the impact of rising premiums. But the nature of what our nonprofit organization does gives me a different hat. We're a peer-led social services nonprofit agency, and we help thousands of Rhode Islanders every year navigate the healthcare system. We operate a program, a health insurance consumer assistance program in partnership with OHIC. We help about 3,000 Rhode Islanders every year, and I'm hoping I can maybe announce, I'm looking at my colleague, we're about to hit a milestone of saving Rhode Islanders $6 million in healthcare costs since 2018. We're at, I think, 5.99 as of yesterday. So we see and hear every day the challenges that consumers are facing, and a lot of it is driven by the cost.
Thank you. So I'm going to start, David, with a question for you. You are a small business employer, and you talked about how you provide health insurance to your employees. Not only that, it seems like you go through great lengths to make sure that that coverage actually meets your employees' needs. And so I was wondering if you could talk about how high and rising healthcare costs have impacted your business, and talk a little bit about what are some of the trade-offs that you face year after year when you see the health insurance coverage that you want to provide going up. What sort of goes through your mind, and what kind of what trade-offs do you have to make for your employees?
Okay. I think the biggest trade-off, especially with a small company that has a limited budget, once I see what healthcare costs are going to be for the following year, that's when I have to review compensation and the possibility of adding or increasing other kinds of benefits for our employees. And first we have to nail down the healthcare costs before I can look at the other factors that are important to our personnel. And my people understand that whether you call it healthcare insurance costs, or you call it life insurance, or you call it paychecks, it all comes down to money. And if we're spending more money to help them with healthcare insurance, that means there's less money in the kitty to help for other things that are important to our personnel. So that's the biggest trade-off. And when it comes to picking healthcare plans, again, with the help of Shop Exchange and HealthSource Rhode Island's resources, what I find is my employees are having the most difficult time picking plans because of the high deductible costs. That's where the trade-off is. Now, they're all kind of, I don't know if I can say this, but I'll say it. They're all kind of shooting crap when it comes to picking the plan, because you're betting on whether or not you're going to need to use the deductibles, and how much, what factors within the plan go towards the deductible versus being paid outright or with a copay and so forth. So they make those trade-offs when they pick the plan, and then I make the trade-offs when we look at other forms of benefits and compensation for the employees.
Thank you. Thank you, David. And Sam, maybe you could also offer a different perspective, since your organization is really on the front lines of helping consumers get access to healthcare. How do you see the issue of healthcare affordability playing out in the everyday lives of the consumers that you work with? Can you tell us some of the stories that you're seeing and hearing from your clients?
Well, I'll make Dave feel better and also say he's talking about his employees shooting craps, and I think in our call center we see when they got a bad roll. People with unexpected costs that they simply can't pay, or unable to access care that they absolutely need. A recent survey, national survey, so this is not just Rhode Island, showed that about half of Americans have skipped or delayed care because of cost, because they were worried about cost. And about a third have not taken their medications as prescribed in the past year because of costs. And we all know people who cut their pills in half, or who take it every other day instead of every day, simply because they can't afford what their doctor has recommended that they do. And we get those calls all the time. You're going to see charts, I think, later today. I imagine you'll see slides showing how much total healthcare spending has gone up in the past decade, 2 decades, year, 2 years, 3 years. All of those trends are very, very scary. But if you look at it a little differently and you just look at the out-of-pocket cost, the portion that's being paid in copays and deductibles that are coming out of pocket and aren't covered by insurance, it's actually much, much, much scarier. The amount of costs that are being borne by patients, they really can't, and it's impacting their ability to stay healthy.
Sam, I have a follow-up on that, because I imagine you help consumers who both have commercial insurance through HSRI and who have Medicaid or other
Yes, we
publicly
help
covered?
any Rhode Islander with any kind of insurance, Medicaid, commercial insurance, Medicare, uninsured. We've helped somebody with tribal insurance a few years ago. Yeah, any kind of insurance. If you're a Rhode Islander, we'll help you.
Are you seeing any differences in the impact of these, high costs on different populations?
Oh,
How is that playing out?
Absolutely. Medicaid is a different kind of program that, you have a lower income population and there's not an expectation that people can pay hundreds of dollars or thousands of dollars to get care. The challenges there are more about getting the coverage, getting into the coverage. I think that we've seen somewhat of a trend actually in older Rhode Islanders in Medicare, and Part D is good drug coverage, but as drugs become more and more expensive and as there become more sort of specialty and high cost drugs, the way that those plans are handling cost sharing, it's more common for consumers to have out-of-pocket costs for prescribed drugs that are really hard to just unbearable.
That's interesting. Thank you, Sam. And then Al, I'd like to turn to you. You've, as you noted, you've been working in this space for a long time and have had interest in affordability for a long time, and you've been long involved in the Cost Trends Project. What role do you see the Cost Trends Project playing in addressing healthcare affordability?
So maybe just to add on for a minute, we don't differentiate between consumers and employees. We think, it's the same people, frankly. And so we've had a great concern about consumer costs, and the more we've looked at the data, the more we see things like median house family premiums, the average family premium here in the state, having approximately 28% of median household income, according to the Medical Expenditure Panel Survey, and our deductibles are going up, some of the highest in the country. I think our family premiums now, according to MIPS, are somewhere in the neighborhood of the 13th or 12th most expensive in the country. So I look at cost trend as a place, given that markets don't work in healthcare, frankly, and we know that, that's pretty well established, that I look at cost trend for a place where we can go to create the pressure for change so that we can soar with the eagles, so to speak, rather than flying with the turkeys. And the reason why I say that is because in the beginning, I think the very first meeting of cost trend, I was one who said, look, I think we need to meet the cost trend goal for sure, but let's not kid one another. If we just meet that goal, we are not going to have affordable health insurance. It's just that simple. When you look at the three buckets in premiums, hospitals, specialty docs, and RX, if they're going up 3% per year, you're just not going to do it. So I see the Rhode Island Cost Trend Committee as a venue for creating pressure for change. It has everyone, if you were to put up a list of who needs to be in the room to do it, it has everyone in that room. And I think what we need to do is use this venue to create that intense pressure for change that's necessary to make change in just about anything in this country.
So kind of following up on that, what kinds of initiatives or actions would you like to see taken,
Well, as we've gone around talking about the Cost Trend Committee, or the kind of the area that I always focus on is payment reform. I think it's probably the most critical aspect of what we're talking about here in the state. I speak from experience in that I was in a community business sponsored payment reform methodology in Rochester, New York that lasted for almost 10 years. And during that period, the incentives changed. We went from fee-for-service to non-fee-for-service, and we actually underspent the national average in hospital costs by $0.4 billion over a 10-year period. The following 10 years, we overspent the national average hospital cost by $1.6 billion because the incentives change. So for me, payment reform, and when I say payment reform, I'm not just talking about a value-based system that is underpinned by fee-for-service. That, to me, is not payment reform. Payment reform is a system where we move away from from fee-for-service, and where we're absolutely certain that the leadership of the healthcare system are totally aligned with affordability through incentives.
Thank you all. We do have a panel later on VBP, value-based payments, so hopefully we will hear a lot more about what our Rhode Island leaders are planning in that aspect. David and Sam, I was wondering if you have anything to add around what types of actions you would like to see happen coming out of this cost trends project.
I think you've got listed it on the agenda today. With the cost trends steering committee's recommendation or compact that was just signed recently that I had a chance to look over, I think it hits the major points, and we realize you got to walk before you run, and run before you try to do a marathon, but we got to get started. And I think what's listed and what's going to be described in later panels today is what we need.
You know, I think that the approach of the Cost Trends Project, one of the things that's so exciting and unique about it is how it views the healthcare system as a whole for all payers, all large providers, and it's really incredible to think about how little data policymakers have about the healthcare system as a whole when you think about what a big part of our economy it is. Two things that I would like to see come out of this work. One is, you know, there's two different ways healthcare costs can go up. They can go up because we're using more services, or they can go up because the cost for each service is getting higher. And I think a lot of our interventions over the past 10 years or so have really been focused on the utilization side, how much healthcare we're using. But I think a lot of the data indicates that it's actually the unit prices going up that's driving increased spending. So I hope that this project can shine more light on that and collect the requisite data to allow us to make those determinations and to direct our interventions in places where they'll be most fruitful. I think the second thing that I would like to see come out of this project is a little different direction than we've taken so far, but we're just starting to move that way, is we really have two crises in our healthcare system. We've been talking about spending, and our nation is spending twice as much per capita as other developed nations. But we also have a crisis in outcomes. We have among developed nations, we are the worst in life expectancy, maternal mortality, infant mortality, really like core things of what is the healthcare system for. And I would like to see this energy and analytics and brain power and consensus building brought to bear on some of those problems as well.
Thank you, Sam. Sam, I was wondering if you could also comment on, you know, these health equity obviously plays a big role in this as well. And wondering if you could talk about how do you envision incorporating health equity into these efforts that you, Al, and David have talked about.
Yeah, you know, I think that really just following up on what I just said, maternal mortality, we are 54th in the world in maternal mortality. We're on par with Latvia as a nation. That was not always true, actually. 20, 30 years ago, we were on par with other developed nations with a maternal mortality rate of around 7 per 100,000. Most of the developed world, it's now around 5. In America, it's now between 20 and 25 across races. And it's 4 or 5 times higher for black women than it is for white women. And I don't think you can get at health equity without looking at these core public health outcomes and really focusing on them. And if we focus on maternal mortality, just to give one example, it could be childhood obesity, it could be lots of different things, and we actually try to move the needle on those things, we won't be able to do so without also impacting equity. So again, I hope that all of this resource and energy can shine a light on those challenges as well.
Thank you, Sam. David and Al, I'd like to kind of pivot back to you. You talked about value-based purchasing as really kind of very important in terms of moving the needle on affordability. Talk about what role you see employers playing in pushing forward these types of initiatives.
I think the biggest issue we face with getting employers more involved is to make them aware of what's going on, and when their input is warranted, requested, or needed, we've got to find ways of getting that information to them. A perfect example, I look around the room this morning, and HealthSource Rhode Island defines a small business for purposes of shop exchange as 100 employees, and how many owners of small businesses, 100 employees or less, are in the room today? There we go. We've got to, it's not because they don't care. I mean, they see the bottom line, they see the costs and so forth. We've got to find ways of getting them more involved. And I think it's through associations like Rhode Island Business Group on Health, and also through many of the people in the room that represent insurance companies, providers, and other government agencies. We've got to find ways of getting the business owners involved in the discussions. I think that's what we got to do.
Al, any thoughts you want to add?
I've given, over the years, a lot of thought to involving business, and the reason for that, and when I say business, from my perspective, is business and community leaders. In any community, there are people, maybe 20, 30, 40, who fall into the category of what I would call business and community leaders. And the reason for that is the experiment that I was in when we were first approached by Kodak, Xerox, and Bausch. We said no, and thought, well, that's the end of it. But the reality is they turned the pressure up on us intensely so that we couldn't get out of the way of the thing. And finally, we decided to give it a try, and were shoved into it literally. I also want to tell you that 3 years in, to hear us tell the story, we did it. It was our invention. So from my perspective, I think we need to do a couple things here in Rhode Island, because you don't have a Kodak, Xerox, and Bausch. The first thing you need, and by the way, neither does Rochester anymore. Those companies are really very small. But the first thing I think we need to do is stop speaking in tongues. So in healthcare, we speak in tongues. And we think if 5 pages is good, 10 pages is better, and 50 slides is just the way to go. And I remember the CEO of Kodak one time said to me, "Can't you boil this down to 1 slide?" And I thought to myself, oh my God. And I never did boil it down to 1 slide, but we need to do that. We need to stop speaking in tongues, and we need to provide pathways for them to become involved. And it's not asking small businesses to come to meetings every month. It's simply asking them to support and make a call, occasionally write a letter, and make their wishes known that they want a more effective, affordable, higher quality healthcare system. And by the way, I want to make one other point. The experiment that I was in actually had 2 major goals. The first was affordability, and the second was strengthening the financial position of the hospitals, both of which were achieved.
Great, thank you. And Sam, I was wondering if you could kind of pick up on that thread also, but sort of, putting on your consumer advocate hat, as we start talking about kind of policy initiatives, potential solutions, right? They get very technical very quickly. We all have to think about, okay, how does this get implemented by payers, by providers, et cetera, and in those discussions, how should we make sure that the consumer voice is represented?
It's a great question. I think, like Al, I would say inviting consumers to monthly meetings is probably not the answer either. I think one way to do it is to make sure that the initiatives we're proposing are responsive to the things that are important to them. So I'll just give an example. This Cost Trends project has been very focused on total cost. And for example, on pharmacy spending, last year there were some efforts making some proposals to address the total cost of certain prescription drugs, the cost the insurance company is paying for it and the consumer put together. At the same time, there were efforts in the legislature to limit copays. So the efforts that we were pushing weren't going to limit copays. They were just going to look at total cost. In parallel, there were efforts that certain consumer groups and legislators were leading to limit copays on certain drugs that actually passed. And I think that those are the issues that consumers are going to understand and feel more easily. And it's actually not mutually exclusive. So I think we could do a better job when we think about total cost to say, okay, let's say cost goes down. Who's going to get the benefit of that? How is the benefit of that going to be shared? To make sure that consumers are involved in sharing in that benefit, then we can have consumers excited and advocating, because we've actually seen it happen through proposals that we weren't pushing that didn't address total costs, that were focused on the consumer side of things.
Thank you. So you make a really good point that, slowing down total cost doesn't necessarily translate into something that consumers or employers benefit from. It doesn't necessarily translate into lower premiums or lower cost sharing. And the need to thread that needle is really critical. And so I kind of want to ask sort of my last question, and then we'll open it up to questions from the audience. For you, what would it take for you to be able to say that we have started addressing the issue of affordability? Like Sam, David, Al, what do you need to be able to see? What's it going to take to convince you that we have started to make a dent on this issue?
For me, I think I might have mentioned payment reform. I think what we need to do, if you look at commercial premiums here in the state, the medical expenses underneath there are hospitals, specialty docs, and RX. The big bucket is hospitals, specialty docs, and RX, about the same percent of total expenses. RX is the fastest increasing in the bucket. So I think there's enough sophistication in the room at cost trend when we start to structure payment reform that we just have to be honest with ourselves and say, is this going to lead to major change or minor change? And if we think it's going to lead to minor change, you got to cut that in half, because you never get what you start out for. So I think a real dose of reality and data-driven decision-making is absolutely critical. I think if we keep talking, and I don't mean to disrespect this concept of total cost of care, business people don't understand total cost of care. When you say, here's what's driving your premiums, so if we base it from the product down, they better understand that, and then I think we're taking a step towards educating them. My guess is if the people in the room feel that we stand a chance of really doing something, then we might pursue that concept, whatever it is.
Thank you, Al. David, any comments on that?
Well, I think there's two issues that add up to affordability to the consumer, to the employer, to the employee. One is the control of healthcare costs, but the other thing is how those healthcare costs are paid for. And what I mean by that is whether you're insured by Medicaid, Medicare, or commercial insurance, when you go into a hospital for a procedure, your costs are the same regardless of how those costs are being paid. The biggest disparity we see when we buy commercial healthcare insurance is the fact that the commercial insurer has to pay a lot more for those actions in the hospital than people who are covered by Medicare or Medicaid. Later on today, I think it might come up in conversation about a new hospital tool that's available to the public. And I picked out just one factor in that hospital tool. I picked one hospital in Rhode Island. Don't even have to mention who. We had data from 2019, and when we look at what's called operating cost to revenue margin, the commercial healthcare insurance companies provide the hospital with a 21% margin costs to revenue. However, the Medicaid community participates at a minus 45% margin. So it's costing the hospital $45 for every $100 worth of practice. For a Medicaid patient, they're actually losing $45. And I was surprised that Medicare is at a 11% margin, which is much closer to commercial insurance than it is to Medicaid. And I think that mix of Medicaid, government-supported Medicaid, government-supported Medicare has to be balanced better so that the commercial insurers do not have to pay the amount of total overall costs that we have to today. It's so I think that's an issue that also has to be worked on. Besides looking at the costs of healthcare, you got to figure out how we can be more fair in who's paying the bill.
Thanks. Sam, any last words on that?
Yeah, and I think you asked what would I need to see to see that we're making progress. I think we already are, actually. I think about this in generational terms. This is almost a fifth of our economy. You don't see changes overnight that are gonna, in 1 year, 2 years, 3 years, massively change where we're going. I think if you look at the efforts of the last 10 or 15 years, there has been some progress. And what I would like to see to make me feel like we're ready to make more progress is coming back again to this point on unit prices versus utilization. And to Dave's point there about asking a question, what is it that drives healthcare, the cost up in a commercial market, but not in Medicare or Medicaid? You have different market power, different negotiating structures, and I think that we need to have a better lens into that and understanding those market dynamics so that we can really focus on what's driving the costs in the commercial setting.
Thank you. Thank you so much. This has been a great conversation. I think we have a few minutes for questions from the audience.
Hi, my name is Teresa, and I believe I'm president of the Hospital Association of Rhode Island. It's a pleasure to see so many people here this morning. I've spent a lot of time with these three gentlemen in a lot of meetings over the past couple of years, and I'm a little confused as I listen because David has just hit the nail on the head on the issue of Medicaid and the low rate of reimbursement in our state, and how that is directly impacting the commercial market, which we're discussing here today. So thank you, David. All those meetings are wearing off. However, my question goes to Sam and any others. Sam brought up the issue of equity, and I think it's important given this room. When we talk about value-based planning, one of the things we advocated for was a cost-payer study. You asked January, who's missing in the room at cost trends? And they're there sometimes, but not in the role, I think, of the presence they need to. I would suggest that it's Medicaid, and I would ask Sam what role he thinks when he talks about maternal health mortality. One of the infants are providers, have been leaders. Honestly, Neighborhood Blue Cross has stepped up on this area of equity, as have the other insurers. I do think for us to continue to do that and to make those numbers change, maybe you could comment on what you're seeing in the Medicaid role of consumers equity.
I think that you're right, that the Medicaid rates are a driver of our equity challenges. I think if that was the question you're getting at, and it's clear at the institutional level, if you look at Dave's numbers, that if you're a hospital who has a lot more Medicaid patients, it's going to be a lot harder for you to provide high quality care than if you're a hospital that doesn't. And I think you're never going to get to an equitable system on that foundation. Did that answer the question?
I just think it's important because everybody's working so hard on this issue that
Yeah.
Thank you, Teresa. Any other questions or comments from the audience? In that case, I want to thank Al, David, and Sam for coming here and being part of our panel. Thank you so much for providing your perspectives. And then we'll move on to the next.
Thank you.
Thank you, January, and thank you, Al, David, and Sam, for that really important set of perspectives you were able to offer today. So I'm going to invite Michael Bailett now, as well as January, to come back up, and we are going to have a presentation and discussion around the state's performance in 2020 against the healthcare cost growth target that was set by the members of the Rhode Island Healthcare Cost Trend Steering Committee. So January, I believe you are up first, so please.
Okay. Hello again. All right. So let me just give a. Do you want to wait a little bit? Okay. Let me just give a quick overview of what we're going to go through today. Do you hear an echo? Our presentation is in two parts. First part, I will provide a little bit of a background on how Rhode Island came to establish the healthcare cost growth target, and talk a little bit about the process for collecting data so that we can measure performance against that target. And then I'm going to turn it over to Michael, who's going to show you or go over the results of our 2019-2020 data collection. All right, so I think many of you in this room know that the target was first established in late 2018 through a voluntary compact that was signed by a broad coalition of stakeholders. And that included employers, provider organizations, payers, consumer representatives, and various state agencies. Shortly after that, then Governor Gina Raimondo reaffirmed the state's support for the healthcare cost growth target by taking the terms of the compact and putting it in an executive order. And then since then, an advisory committee, which we refer to as the steering committee here in Rhode Island, has continued to meet to kind of hash out the implementation details for the healthcare cost growth target program. So what is a healthcare cost growth target, right? It is basically an agreed upon goal for annual healthcare cost growth. And in Rhode Island, that was set at a flat 3.2% for 2019 through 2022. And this target applies at various levels. It applies at the state level, the market level, the insurer level, as well as the large provider entity level. At the time, Rhode Island was the third state to establish a healthcare cost growth target, following Massachusetts and Delaware. And then since then, 5 other states have established their own targets. Oregon, Washington, Nevada, New Jersey, Connecticut. And then there are 2 other states, California and Minnesota, that have legislation pending to establish a target. And in Rhode Island and in all of these states, the rationale for establishing the target was really kind of to shine a spotlight on healthcare affordability and what's driving healthcare cost growth, with the eventual goal of undertaking, initiatives and actions designed to try and mitigate and address healthcare cost growth.
So January, if you don't mind, could you talk a little about, you note that the cost growth target has been set through calendar year 2022. If you could just talk a little bit about the plans for when the cost growth target then will now need to be set for future years coming forward.
Right. So if Michael, I'm going to defer to you on that question since you're much more involved in that process than I am. But that is a very good question because 2023 is coming up very soon.
Thanks. Good morning, everyone. So the plan is for the steering committee to meet in June and July to ponder what the cost growth target value should be for 2023 and beyond. And obviously there'll be lots to consider because the status of our economy is quite different than it's been the last few years, but that's the time period to establish it for 2023 and beyond. And exactly how far beyond goes, that's subject to discussion by the steering committee.
Great.
Thanks, Jeremy. Thanks, Michael.
Okay, so just a reminder of what it is exactly we're looking at and what it is we're measuring against the target. We are looking at year-over-year growth in total healthcare expenditures. And total healthcare expenditures comprise two things. The first is total medical expense, which is spending on all medical services for covered residents. By covered residents, I mean Rhode Island residents who get their coverage through Medicare, Medicaid, or commercial insurance. The second component is what we refer to as the net cost of private health insurance, NCPHI, and that is spending for private insurance administration. It's what we typically refer to as the margin or the profit or loss associated with insurance administration. Okay, so those two things, total medical expense and net cost of private health insurance, make up total healthcare expenditures, which is what we look at on an annual basis to assess performance against the target at the state level. To calculate growth in total healthcare expenditures, we had to collect data from several sources. Most of the information, the bulk of the information came from aggregate spending data that were submitted to OHIC by the insurers. We did also have to go out to the Centers for Medicare and Medicaid Services to get spending on Medicare fee-for-service and Part D. We also got data from EOHHS to get Medicaid fee-for-service data, and then we looked through publicly available regulatory reports to help us gather data to calculate net cost of private health insurance. But the bulk of the information comes from the insurers. Okay. This slide shows the levels at which we are assessing and reporting performance against the target. Okay, so 4 levels: state, market, payer, and ACO, AE, or Accountable Care Organization, Accountable Entity level. In the past, I think you have probably seen OHIC present results at the state and market level. For the first time today, or this year, OHIC is going to be presenting results at the insurer and the ACO AE levels. And at these 2 levels, results are going to be stratified by market. So each insurer and each ACO AE is going to have a Medicaid cost growth, commercial cost growth, and a Medicare cost growth, assuming, of course, that the insurer has business in that market and that the ACO AE has enough attributed lives in that market for their performance to be reported. Okay. And so, sorry, something to note too, at the market, insurer, and ACO AE levels, we're reporting total medical expense. And at the state level, we are reporting total healthcare expenditures. The difference being that total healthcare expenditures includes net cost of private health insurance. This year, we introduced a number of methodological changes, all recommended by the steering committee and all designed to give us more confidence in our assessment and reporting of insurer and ACO AE performance. The first of that change is to implement truncation. So we set truncation thresholds at different levels for Medicaid, commercial, and Medicare lines of business, and we did not include member-level spending above those truncation thresholds in our calculation of healthcare cost growth. The second was to move away from clinical risk adjustment to doing risk adjustment only based on age and sex. And then the third was to conduct statistical testing to assess performance. And what this entailed was essentially calculating confidence intervals around an entity's cost growth, a lower bound and an upper bound, and then evaluating making a determination that the entity met or didn't meet the target based on whether that confidence interval was fully above the target, below the target, or intersected with the target. So those three things we introduced this year, and Rhode Island is the first state to implement all three methodologies, although other states are following suit, pretty much.
January, how would you characterize how people should think about the data in light of these changes? And Michael, if you have any thoughts too, given that other states have now moved to adopt them, what does that really mean to someone looking at the data? How should they think about it from data that doesn't have these types of adjustments?
Right. I think it really is, these changes were implemented as a way of getting around issue of small numbers, right? Especially as you get into the ACO AE level. We're worried that, smaller entities, their performance is much more vulnerable to the influence of like a high cost outlier, for example. And so some of these changes these methodologies are really aimed at minimizing that impact and making sure that we have greater confidence in our assessment of that. So.
Thank you.
Okay, so this is a caveat that we always make when we're presenting data, because we know that there are lots of other data and analysis out there. As part of the Cost Trends project, we analyze data from the Rhode Island APCD. Medicaid also releases data on an annual basis on the performance of the Medicaid program. And so we just want to caution against making kind of hard comparisons between the data that we're presenting today and what you're seeing in those other data. They are based on different methodologies. They include different types of spending. The categories of spending may be defined differently. And so that's just something to keep in mind always when you're looking at the data. And then finally, we can't really talk about cost growth or spending in 2020 without acknowledging COVID impacts. We know 2020 was just a highly, highly unusual year, both in terms of utilization and spending. Utilization was down significantly when offices were closed, elective procedures were deferred. At the same time, there was a huge infusion of federal dollars into the healthcare system to help prop up the healthcare infrastructure and support providers through the pandemic. And so, kind of on both sides, it was just, we're seeing spending that we normally don't see. We're seeing utilization levels that we normally don't see as well. I did want to highlight that there are national estimates that spending actually increased by 10% in 2020. And this is driven largely by a 36% increase in federal spending on COVID. The COVID response. And so that is information, that is spending that we do not capture in the data that we are presenting. But it's important to acknowledge nonetheless. And we did want to try to quantify it, even though we didn't incorporate it into our analysis. We wanted to quantify it as best as we could. And so we went to federal databases that track the spending, and they do it by state. And as of July of 2021, we had identified $580 million in payments that went to Rhode Island providers. we don't know if, unfortunately, the way that the spending is tracked is very difficult to know exactly when the payments went and to whom. So, some of this could have been payments in 2020. Some of this may be payments in early 2021. It is possible that there are payments during that time period that are not reflected here as well.
Yeah, and I would just note here that I think the way I think about this, I think January being really clear about the fact that this wasn't able to be included in the analysis, it is another example of the way in which 2020 was an anomalous year. It's still important. We think there's still, as you'll see, important conclusions that can be drawn from the 2020 data, both methodologically and substantively for policymaking. But I think the transparency about this is really important. And the way I think about this from a public policy standpoint, and probably the way many of you think about it, this was absolutely critical action by federal and state governments to ensure financial stability for the provider community during the pandemic. So I think it's important to recognize that it's not in the analysis. It's important to recognize the effect that it's projected to have had nationally on healthcare spending for that year. And I think it's worth thinking about as we move forward. How the implications of that spending and the challenges that that spending was being responsive to, how that impacts the work we're all going to do going forward. So I really think it's really important contextual information, even though it's not directly included in the analysis that you'll see today.
Thank you, Patrick.
Sure.
And then also we did ask EOHHS to report to us COVID payments that they dispersed in 2020, and what they had identified was about 275 million in COVID payments outlined here. About 35 million CARES Act payments, nearly 15 through the Workforce Stabilization Program, 500,000 for the COVID intake centers, and the bulk went to hospitals, 220 million through the Hospital Assistance Partnership Program. Again, the overlap between this figure and the figure I presented before, it's hard to know, but just important to note for context, the payments that went out. So that is the background information, and I'm going to now turn it over to Michael to present the exciting stuff.
Thanks, January. So the exciting stuff. Just context, what happened before 2020? So 2020 was the third year of performance measurement against a cost growth target. In the two preceding years, spending was above the 3.2% target that was set by the steering committee back in December of 2018. You can see in 2018, that was the baseline year, so it was before the cost growth target became effective, and cost growth was about 40% above the target. In 2019, it was a little lower, but also significantly above the target. So in 2019, this meant that there were about $66 million spent on healthcare that represented the delta between the target and the actual spend. So who spent that $66 million? It was a mix, as you might expect, of employers, employees, and government. And of course, when it's government, it's really all of us as taxpayers. Okay, so this is what brings us up to 2020. So what happened in 2020? A really strange year. Spending declined on a per capita basis, 2.9%. This finding is consistent with what we've seen in other states, where the decline was somewhere between 2.5% and 3.5%. That's looking at about 5 states that have reported so far. And again, to the point that January just noted, this does not include the $580 million of federal spending that was really economic relief, or that $275 million of EOHHS spending. And I want to acknowledge we're not even sure if those are two completely distinct categories. But so these are just payments that were made by public and private payers for services or under contract between payers and providers. If we look at the breakdown of the spending, so overall it was about $8 billion of healthcare spending in 2020. You can see that in declining order, Medicare was the biggest payer, followed by Medicaid, followed by commercial, but they're all in the $2 to $2.5 billion range. So there's pretty evenly split spending across those 3 large payer categories. That last category on the bottom, net cost of private health insurance, again, that's private insurer admin and margin. I want to note that all of those categories in gross spending declined in 2020, except for the net cost of private health insurance, and I'm going to explain a little bit about that calculation later on. So let's look by market. What happened? Commercial market declined by 3%, so about the same as the state average. The per capita spend, $5,800 in 2020. The decline in Medicaid was larger, 6.1%. Now, the per capita spend in Medicaid is above commercial at $7,200, so that compares to $5,800 for commercial. And then finally, the decline for Medicare, 5%. And you can see the per capita spend for Medicare is significantly above both Medicaid and commercial, okay, at over $12,000. Now, if you look at these three percentages, 3, 6.1, 5, you look at them together, they're all bigger than the state percentage of 2.9. Why is that? That's because the net cost of private health insurance actually grew. So that's how we get to a lower rate of decline than you see in the three markets. So let me talk about the net cost of private health insurance. So this calculation, admin and insurer margin, which can be profit for a for-profit insurer or contribution to reserves for a nonprofit, it has to be viewed with a little bit of caution. First of all, we found over time that it's a very volatile figure. If an insurer has a loss one year and a gain the next year, the net cost of private health insurance is going to swing wildly on percentage terms. Okay, so that's one issue. The second is the way that OHIC collects data on the net cost of private health insurance is to look at filings with OHIC from insurers using federal forms. The insurers provide information for their fully insured business and sometimes for their self-insured business, but not always for their self-insured business. So when they don't, it's necessary for OHIC to look at the corporate financials of the insurer that does not provide it for their self-insured business, which means essentially we're making some estimates. Okay, so there's some imprecision there. And then finally, for this particular year, it turns out that there were some contractual recoupments that EOHHS made with Medicaid MCOs that were not captured here because they were made after the measurement period. So we know specifically for Medicaid that the net cost of private health insurance trend is overstated. Okay, so a whole bunch of qualifiers when looking at this information. Oh, sorry, I spoke faster than my bullets. All right, so here's a breakdown of net cost of private health insurance. Grew 14%, again, with all those provisos. $750 million. You can see the breakdown here in the commercial market between self-insured and fully insured, and then within fully insured, you can see a breakdown of large group, small group, and individual coverage. Okay, about $800 per capita on admin and margin in the state in 2020. So this is the change by the markets, and obviously two things jump out here. One is the individual market, huge increase there, and the other is the two Medicaid programs, the Medicaid MCO and then FAI duals. That's a neighborhood health plan product for people who are eligible both for Medicaid and for Medicare. And as I noted, there were some contractual recoupments that are not reflected here. So I think I can say with confidence that the actual rate of growth would not have been that high if the recoupments had happened during the measurement period. Okay, overall, this is $724 million of spending. So that's a significant amount of spend. It's also, though, quite small compared to the total medical expense or the healthcare spending. So this is not a meaningless percentage, and it's a lot of money, But when we look at overall trend, what's driving spending in the state, it's payments to providers, not insurer admin and margin. All right, so next, I'd like to look at what was happening in terms of spending patterns at the service category level. So when payers report their data to OHIC, they don't just report total spending, but they report spending for inpatient and outpatient hospital, for retail pharmacy, for professional spending with specialty and primary care broken out. So we're able to see what was happening in those different service categories. So first, I'm going to share with you what was happening at the state level, and then we'll show data by market. So let me orient you to this slide. So on the y-axis, we have per capita trends. So this is the change in spending per capita between 2019 and 2020. On the x-axis, on the bottom, what we see is the per member per year spending amount. So that ranges from 0 in the left corner to $4,000 way out here, per member per year. Those circles in the middle represent the contribution to spend for different service categories. The larger the circle, the bigger the contribution to trend, be it positive or negative. Okay? So, and finally, when you look at those big circles, the actual rate of growth is the center of the circle. The very center is the actual rate of growth. So what we can see here is, not surprisingly, most of the circles are below 0. Okay, so we have negative trend on a state basis. But there's one that is significantly above 0. Okay, that purple circle is pharmacy. Okay, so pharmacy trend was 8.3% for 2020 in Rhode Island. So spending went down every place, but not in pharmacy. I will share with you, having recently looked at comparable data from other states, this is not a pattern that existed only in Rhode Island this year. In fact, last week, there was a public presentation of trend in Nevada, and their pharmacy trend was double digits in 2020. Okay, so not as in most trends, I will say, in spending and utilization, patterns are not specific to individual states. There are some general patterns that ripple across all the states, and pharmacy spend is one. So at a state level, that's our only positive or plus cost driver. Everything else had a reduction in per capita spending in 2020. Let's look at the individual markets now. So this is the commercial market. This looks a little bit different. First, pharmacy trend, and again, this is retail pharmacy. Retail pharmacy does not include what we sometimes refer to as medical pharmacy. Medical pharmacy represents physician-administered drugs, sometimes referred to as infusion drugs. Those claims don't show up as pharmacy claims. They show up as physician claims and hospital outpatient, okay? And they are a significant source of spending growth, but they are not delineated here. We did not capture medical pharmacy separately, so this is retail pharmacy. So this is at CVS or mail order or however people have their pharmacy benefits provided. So 10% growth here, higher than the state average for retail. And then there's that purple circle, other claims, 44%. So that obviously captured our attention. What might that be? It turns out that a significant percentage of that is payments for COVID testing. Okay, I would say that's, you know, a trend that certainly is going to decline over time, but other claims is normally a very small category, but for this 1 year, it had significant growth. You can still see overall that in terms of per member per year spending, it wasn't very great. It's way over on the left corner, but the growth was tremendous. Next market is Medicare, and here again, pharmacy is positive, everything else is negative. The retail pharmacy trend here was lower than it was for commercial. It was 4.9, I'll call it 5%. And then Medicaid. So Medicaid spending is heavily influenced by long-term care, which makes it much different than the commercial Medicare markets. And that giant blue circle is negative 12% trend in long-term care. So that had great influence on overall trend for Medicaid. But retail pharmacy is positive. Now, retail pharmacy per member per year for Medicaid is lower than it is for commercial and Medicare. As perhaps most of you are aware, Medicaid gets very large rebates for pharmacy, and so that drops the value of spending on a per member per year basis. Nonetheless, retail pharmacy still grew 16.5% for Medicaid in 2020. One last note about pharmacy. I can't say if this is true for all three markets, but we do know that in the commercial market, that perhaps one contributor to pharmacy growth was that in 2020, commercial insurers were more permissive of 90-day refills than they traditionally would have been. And that was in response to the pandemic. How much impact that had on trend, I can't say. Was that also standard practice for Medicaid and Medicare? I can't say, okay? But I do want to note that that was yet another thing that was different about 2020. All right, so if there's a message looking at all this trend, it's that there was a lot of growth in pharmacy. I want to put this in context with what we've seen in prior years. Per capita pharmacy growth has been high historically. In 2019, it was 7%. And Brown performed an analysis looking at 2016 to 2018 data, and they found that during that time period, half of total growth in total medical expense was associated with pharmacy spend, and almost all of that was due to price. Or actually, all of it was due to price. There was no change in utilization in the commercial market. In Medicaid, a little bit less, 41% of total growth in total medical expense was due to pharmacy, and that was mostly due to growth in price. So what we saw in 2020 with pharmacy was not a one-year phenomenon. In fact, going back to 2016, pharmacy spend has been if not the principal cost driver of healthcare spending in the commercial and Medicaid markets. And I can't say for 2020, but at least for earlier years, it was all about price. I will share again, looking at other states, that when we look at pharmacy spend growth in other states, it is primarily about price. Utilization of retail pharmacy has not been growing significantly in the U.S., at least for the states that we've seen data for, but price has. And when we say price is growing, I also want to note that there's a nuance here. There's change in price for existing market drugs, and there are new drugs coming in at higher price points. Okay, I'm not delineating those here when I talk about price being a driver, but obviously if we want to understand better what's going on, we should delineate between changes in existing drugs, be they generic or specialty, and the introduction of new drugs at higher price points.
So, Michael, a policy question kind of prompted by your discussion of pharmacy and the consistency we see in its growth, even in a highly anomalous year like 2020, when really, as you pointed out, all other healthcare spending categories went down. And we see, as you also have pointed out, this has been a consistent finding of the work in terms of pharmacy driving cost trend. Could you talk a little bit about, based on your work in other states, what are other states thinking about in terms of policy solutions? Sam referenced that the steering committee earlier in previous years has acknowledged this and focused and recommended policies here, like reference pricing and unsupported price increase penalties to try to get at the underlying total cost of drugs. Sam also mentioned various legislative efforts, both in prior years and the current years, to try to address consumer cost sharing at the point of service. That's something OHIC has been very supportive of. But could you just talk about what other states are doing, just to give us a sense of how states are thinking about that, given the consistency in it being an issue across states?
Yeah, this is creating consternation everywhere. I would say there are three categories of strategies thus far. I will also say no state has yet demonstrated success, but there's lots of effort. So approach number one is creating upper payment limits for drug prices, and there are two states that have created prescription drug affordability boards intended to set the upper payment limits. Those are Colorado and Washington. and they're still getting going. I'm a little skeptical about those programs because they're targeting 12 drugs, a year. So, is that going to have a lot of impact on trend? I don't know. Second approach has been international reference pricing, which bills which set limits on drug prices, usually linked to Canadian drug prices. There's been legislation introduced to do this in 6 states, including in Rhode Island. The legislation has not yet passed in any of the 6 states. And then the third approach, which is a New England state approach that's been proposed by the governors of both Connecticut and Massachusetts, is to create penalties on excess prices. That is to say that if prices grow more than CPI plus X%, then there's a penalty assessed. And the bills in Massachusetts and Connecticut are nearly identical. They were filed last year. They were filed both again this year. So those are some of the strategies. There are some other ones too that I haven't mentioned, but I'd say those are the 3 principal ones.
Thanks, Michael. That's really helpful context.
Okay, so now I'd like to share with you, as January said, for the first time, performance at the insurer level and then at the ACO accountable entity level. Okay, we've never done this before. So these are the confidence intervals that January was referencing. So this is commercial insurer performance against the cost growth target. So you see those vertical lines with a little dot in the middle. The dot is the actual rate that was calculated using insurer data submitted to OHIC. The line represents the statistical range that could be the actual performance of the insurer. So the dots are calculation, but we are, if we want to say we're confident, we're actually confident that actual performance was anywhere on that line. So what we see here is that Blue Cross, Tufts, and United Healthcare below 0 and below the line. Okay, neighborhood has a confidence interval that crosses the line. So if it crosses the line, what that means is we don't actually know if neighborhood's trend did or did not fall below the benchmark. If that vertical line was completely below the red dotted line, we would say neighborhood was below the benchmark or the target, okay? But we can't say because the confidence interval crosses the line. You'll see the size of the vertical lines is variable. Neighborhood has a much longer line than does Blue Cross. Why is that? Because neighborhood's commercial enrollment is much smaller than Blue Cross's. So because our statistical confidence is going to relate directly to population size, we're going to be much more confident in our measurement of trend when there's a very large population than when there's a smaller population. So you can see tiny confidence interval around Blue Cross because of the size of the enrolled population. Okay, so here we conclude 3 of the insurers for the commercial market met the cost growth target, and the 4th, we can't make a judgment. I will say in most years, we're going to have performance that's not going to be far below the target, and we are likely to have more examples of lines that cross the target, where we can't render a conclusive judgment. So this is the Medicare market, just 2 carriers, and you can see both far below the target, although their trend rates are much different. They're both far below 3.2%. And then for Medicaid, again, all 3 below. The Tufts confidence interval is far, far larger because their Medicaid enrollment is far smaller. Let me pause before I go on, just because this is the first time that we've ever shared this before. Does anyone have any questions about these data and what they mean? Right in a row, you guys raise your arms.
I noticed, your green circles on your cost trends, you lump all professional physicians together into one basket. I wonder if, as you've analyzed the data, you've been able to squeeze out the primary care
Yes. Well, so what we're measuring here is the contribution to trend, not the contribution to cost. Okay? They're two different things. Yeah. So I don't remember. We do measure primary care separately from other professional services. But primary care as a percentage of total spend is small, so its contribution to trend is likely to be negligible. Okay? But I can't tell you the exact answer. Teresa? Okay. Dan?
Just curious, where does the neighborhood dual eligible population fall into these?
They fall on the next slide.
Excellent question, Dan.
There you go. Okay. So this is the dual eligible product, which a neighborhood calls integrity. Okay. And it had a negative trend for the year. All right, so now let me show you what we see in the ACO AE market. ACO is Accountable Care Organization, so these are large provider entities that are contracting with Medicare and commercial insurers for the total cost of care for all the patients attributed to their organization. Accountable entities are the Medicaid version of accountable care organizations. So I'm going to share the commercial ACO performance first. So you can see there are 4 commercial ACOs that have their data reported here. I want to note for these ACO slides that we're only reporting on organizations that had enough patients attributed to them to meet a minimum threshold. If the number of patients attributed were below the threshold, we're not reporting the information because the confidence interval would be just enormous, okay? So there may be on some of these slides, you might look at them and say, hey, why is organization X missing? The reason they're missing is because the number of attributed patients to the ACO was too small to meet our threshold. All right, so here we've got 4 ACOs. They all had trend between negative 1.3 and 0.34%. When we look at the trend of the commercial ACOs, you might think, well, what's the trend of the commercial market? Remember, you only get attributed to an ACO if you have an established relationship with a primary care provider. So there are some people with commercial insurance who never went to a primary care provider. They're never going to be attributed to an ACO. Or they do have a primary care relationship, but the primary care provider is not part of an ACO. So there's a lot of commercial spending that is not represented here. Okay? This is Medicare market. Again, 4 organizations. In this case, their trends were all negative and all below the target. And then Medicaid. So they're all below the target again. All but 1 are negative. You'll see the size of the confidence intervals are much larger here than what we saw for commercial and Medicare. It's because the populations are smaller. Okay, but again, all at the target, although their trend was quite variable, ranging from 1% to minus 8%. All right, so in summary, I think there are 3 takeaways that we can and should take. The first is we confirmed that we were able to apply 3 new methodologies to do this measurement. That's a big deal. No other state had ever done this before, although there are other states, as January noted, that are adopting some of the same methodological features. I think these changes mean that we can be very confident in our assessment of performance against the cost growth target, not just this year, but on a go-forward basis. So that's something to celebrate. 2, while overall spending went down, that huge volume of federal relief spending certainly suggests that overall healthcare or spending, or at least payments to providers, did not go down. So I don't think we should all go home and say, wow, spending went down 2.9% in Rhode Island in 2020. That's probably a little misleading. And then finally, retail pharmacy continues to be a major problem in our efforts to attain affordability in the state. And I don't think we're ever going to hit the cost growth target if we don't find a way to slow spending growth in the pharmaceutical sector. All right, I've got a little coda for this presentation, and maybe a sobering one, but I want to look to what may be coming. So I'm going to share with you slides that have historical spending in Rhode Island as measured through the Cost Trends Project, and then forecasts through CMS. So this is total forecasted spending, historical Rhode Island, and then forecasted US. We don't have a forecast for Rhode Island. So you can see 4.4, 4.1, negative 2.9. We have that little orange dot above because CMS says, well, actually spending grew 9.3%. Okay. And then what's forecast for 2021 and beyond? Back to where we were before, over 4%. Okay. This is total spending. We then looked at what did CMS forecast for the commercial market, because that's where trend has been highest. Super high. Okay. 5.5, 8.3, 7.2, 5.6 going out to 2024. So that's our challenge in front of us, and the reason for the Cost Trends Project being. And why don't I stop now and we can have some discussion questions.
Great. Thank you, Michael. I think we just want to open it up now for any questions from the audience. It looks like Andrea, you want to jump in?
We have that information, and I don't remember the answer, Andrea. But yes, we do collect it. We collect it both, I think, for patients who are attributed to a PCP and those that are not. Well, actually, I'm not sure about that. But we certainly have it for people who are not attributed to an ACO. Chris?
Yeah, I can take a pass at that. Thanks for the question, Chris. So certainly there are different processes with different data sources, and obviously the standards that OHIC brings to bear when it reviews health insurance premiums are the ones that we are required to do in our statute, which is both are the rates in the public interest and are the rates actuarially sound. So are they reasonable to be what the insurer needs to collect to cover its costs, and we try to balance those standards as we do each and every year. So certainly they're not one-to-one. As Michael in January noted at the outset, cost trends data is different from a range of different data sources, but I think it's important. I guess my overarching point, Chris, would be twofold. One is that they are different data sources. They need to be recognized, the different use cases and what's happening and the standards that are applied to them. But then secondly, I think where there's a convergence or a similarity is that ultimately, directionally, I think the way I think about it ultimately is if we are successful in the cost trends work, one benchmark for that will not only be are we hitting the cost growth target, but are we seeing premium growth mitigate over time. So I think it's very reasonable to expect as an outcome measure that over the medium and long term that we see lower rates of premium growth if we are serious and we can demonstrate that we're consistently hitting or even achieving better than the cost growth target directionally. Because ultimately, as we all know in this room, but I think it always bears remembering, fundamentally, healthcare premium growth is driven by the cost of healthcare. It is not driven by, there are some other factors, but overwhelmingly. So this work very much to try to create greater affordability while ensuring provider sustainability and better outcomes in the cost trends work, it is very reasonable to think of healthcare premium growth as a critical outcome measure. And as we heard from on the first panel with Al, David, and Sam, that's ultimately what employers and consumers care about. And it's what they should care about.
Hi, thank you for
So telehealth claims would be included in here. So that's in the 2020 spending.
And any ability to make some assumptions about its role in contributing to the decrease in costs?
So no. We can't do that here. There's a parallel strategy that's part of the cost trends project that we refer to as the data use strategy, which is mining the all-payer claims database to get more nuanced understanding into spending patterns, because all the detail we get is spending by those broad service categories that were on the bubble graphs. These claim-based analyses allow us to look at specific questions like that one.
Yeah, and I mean, I would just jump in and say, separate but complementary to the cost trends project as well, OHIC has been prioritizing expanding access to telehealth and monitoring what the impact is. And so we've done, independent of this work, but drawing on some of the same data sources with our partners at EOHS, looking at the APCD and looking at the impact, particularly in 2020 and 2021 and going forward, that telehealth has had. I think, again, I don't want to overly simplistically characterize the data, but fundamentally what we found, at least in the short term, was that largely telehealth, particularly during 2020, was having a substitution effect where it wasn't necessarily increasing utilization in many places. It was replacing utilization, of course, that people otherwise would have had. I will say one area that has been notable, and I think this has been consistent with other areas of the country, behavioral health, particularly on the outpatient side, you did see a net increase. And I would argue that's the kind of net increase, particularly during the pandemic, that you want to see. I think that's positive increases in utilization, but something that the kind of analysis that Michael's talking about that we can do through cost trends, that we can do outside of it, is going to be really critical from a policy perspective as we move forward.
My question really is trying to grapple with this Medicaid issue. Medicaid doesn't pay what it costs to take care of people. So it is contributing to increasing commercial costs. So when we look at this kind of analysis, if we want to decrease the rate of rise in commercial, we need to increase Medicaid spending. But how do we think of that in overall cost trend? Like, what would it look like if so if I'm looking at that graph right there, it's kind of scary. But I know, I think Dave mentioned a number, I can't remember, but something like Medicaid pays 45% of what it costs to hospitalize somebody. If we just look at commercial without really recognizing that Medicaid is getting further and further away of paying what it costs to care for people, how can we come up with a model that would say if we truly paid what it costs to take care of people?
So I have a two-part response. One is, if there was ever a public consensus decision that the state wanted to invest more in Medicaid in a given year, and that was going to push Medicaid up above the cost growth target, then we would interpret the results accordingly. We'd say, well, of course it went up because the Legislative Assembly made a commitment that it wanted to increase investment in it, okay? So that's part one of my response. Part two is completely different. Part two is research in other parts of the country has shown that when there are increased investments in Medicaid, you do not see a reduction or even a slowing of growth in the commercial market. So I don't know that we could actually assume that if there was a big investment in Medicaid, that we would see a countervailing adjustment in the commercial market.
Yeah, and Pat, I think the only thing I would add in response, in kind of a friendly amendment to Michael's comments, I agree with everything he said. As a former Medicaid director and now trying to lead this work and work with our partners at the Medicaid office and many people in this room, I would say that what Michael said is certainly true in the literature. I think that there is a way from a policy perspective to square the things that Michael has said, which is both that you see in certain data sets, and referenced earlier, I think David referenced the NASHP hospital cost data set that OHIC is it's already publicly available. We're going to make it particularly accessible for folks here in Rhode Island starting next week, so people can easily access that. But you absolutely see in that data that exactly the point you're making, that there is a variance between Medicaid costs and Medicaid financial performance by the hospitals. I think if you want to achieve from a policy perspective what you, I think, were intuiting of a rationalization of the reimbursement scheme to have provider financial stability and affordability, I think it's not enough. I would view increased Medicaid reimbursement as necessary but not sufficient. You can do that to address the issue that you see in the data there, but then you also have to have constraints on things like market power and commercial pricing to ensure that you see the benefit of that on the commercial side. So I think both things are true, but they require different policy approaches: increased reimbursements in Medicaid and price controls and other measures, some of which we have already in place here in Rhode Island. That's how I think about it from a policymaking standpoint.
Sam?
Sam Salgonic again. I think those scary high trend projections are probably, I imagine, a reflection of people's visions of the labor market now and going forward. And as we get together as an advisory committee and start to think about how we should place our target for out years, how do you or Patrick, how do you guys think we should take the dynamics of the labor market into account?
Do you want me to start there, Michael, and you can join in too? So I think, first of all, I think it's going to be a really important public conversation that we have with all the members of the steering committee, because I think we need everyone's best thinking to be brought to bear on this, because it's not an easy question. I think my simplest answer, Sam, at this point is I think we have to take it seriously. We have to take the labor market dynamics seriously. Those are real effects and I don't think we can afford to ignore them. At the same time, as we heard from you and your colleagues on the first panel, employers and consumers are continuing to experience unsustainable cost growth. So we have to reconcile those and balance them in some way. So my perspective is that we have to think about ultimately a result of setting the cost growth target that pays attention to that reality empirically, but also recognizes what our overall aspirational goal is. So what that actually looks like in practice, we'll have to talk about that together. But that's why I think the consensus-driven process of the steering committee is so valuable, because actually we have a great track record of balancing all of those perspectives and coming out with something that everyone can voluntarily agree to and be held to.
And then Al.
So, good morning, Aaron Robinson, South County Health. So, just an observation on the data and then a couple of questions. So, the last slide you had was around the only slide that we looked at national trends, and the earlier trends were only relative to Rhode Island. So, Rhode Island, despite popular belief, doesn't exist in a vacuum, right? We exist
Sure. Thank you, Aaron, for the question. And I think definitely happy to other members of the steering committee who are here today. Folks have their perspective. Certainly welcome that as well. I would say, Aaron, I really think of it really twofold. And actually, I think it directly relates, and that's the conceptual frame that I think we should bring to the work this summer of setting the cost growth target as we go forward. And so I want to note that not only are we going to be setting the cost growth target, but because the original target was set by this compact that we all signed on to, the mechanism will be we will amend the compact to set that. And so there's also an opportunity that we're going to expressly put on the agenda to some of the points I think Sam was raising earlier about broadening the charge of the cost growth work to explicitly account for things like access, equity, and outcomes. And so the reason I mentioned that is because that's how I ultimately think of the public interest. I think we have to fundamentally do two things. We have to achieve over the medium and long term more sustained, or rather I'll say it this way, lower rates of out-year cost growth in a way that's sustainable for employers and consumers. That's not the case today. That needs to be the case in the future. At the same time, we have to make sure we're sufficiently resourcing the healthcare delivery system to make good and deliver on those access, equity, and outcome issues. And there's a natural tension there that we should just be explicit about. And I think our goal, my goal as a policymaker, and my goal in the work with many of the people in this room is to how do we balance those two things together to achieve the system and the outcomes for Rhode Islanders that we all want, that I think everyone is genuinely aligned in wanting to achieve. It's not easy, and how we strike that balance in a given time period is going to vary based on what's happening. But that's how I think of it, Aaron, is trying to balance those two things fundamentally, affordability and sustainability.
Yeah, and I appreciate that. And I would just say that, what is absent in these conversations from my perspective sometimes is the market that we compete in. And, we want the best doctors, the best nurses, the best pharmacists, the best technology when we or our loved ones are sick. But we compete in a market where Mass and Connecticut have significantly higher rates of reimbursement across all legs of the stool, Medicaid, Medicare, and commercial. And so doctors, nurses, and other clinicians are acutely aware of that delta. And so, again, every year we turn the calendar, we're in a whole 2% as it relates to the cost to even break even on keeping our clinical staff here compared to the rates of reimbursement increases. And that is a perpetuating cycle where we continue to get further away in competing with those states. So I think at least regional comparisons as we look at this work, if not regional and national, let's look at Rhode Island, but we have to acknowledge that we compete in a region, and those costs are real. They're macro. They're not only controllable by Rhode Island.
And I think, Aaron, the only thing I would just add in response to that, I agree that thinking about regional competitiveness and the impact that has is an important frame and should be brought to bear. I agree with that. But I think we also have to note that even though we are competing with our neighbors, we also have to look at Rhode Island's economic differences and ask the question of, does Rhode Island have the ability to pay? Because Rhode Island, for instance, has lower median income than our neighbor states. So I think both things are true at the same time, right? It's not as simple as either saying, well, we need to be on benchmark or on par with our neighbors. We don't have the same ability to pay that our neighbors have. That doesn't mean you allow increasing gap that could detrimentally impact ultimate outcomes. But I think we have to think about that holistically and say, how do you get there?
I know we have to go to our next panel, so two last hands. Al, you first.
Yeah, I wanted to pile on just really briefly to what Aaron's saying, because we could be dramatic and use words like our healthcare workforce has been decimated, but it's actually worse than that, because that would be 1 in 10. It's more like 2 in 10. It's more like 20% of the healthcare workforce has left the profession. And because you take that and you add it to the wage differentials and benefit differentials in neighboring
So the spending that we're showing are payments made by payers. It doesn't really reflect in any ways where the funds came from to make the payments.
So I think another way of saying it is, Lisa, is it won't have any effect because you're just measuring the total, not how much is by source of general revenue or federal expenditure.
I guess the question came to me because when I saw that Medicaid on the national level per capita, they increased their target is at 9.3%. They have increased their spending at the national level by 6.2% to the states. And so I guess that was where I sort of got an implication, an understanding that there might be something else.
Yeah, the 9.3% was what CMS said national healthcare spending grew at, not Medicaid, total national spending. Okay, why don't we pivot to our final panel?
Great. Thank you, Michael. And if I could invite up Al Caros and Michelle Letterberg, my fellow co-chairs, for our last panel. Whatever you want to do.
Boy, girl. Boy, girl.
Okay, so our last topic of the day brings us back to value-based payment, which we heard about a little bit during the first panel. A little bit of context here. Earlier this month, 21 members of a subcommittee of the Cost Trend Steering Committee voluntarily signed a compact committing themselves collectively to accelerating the adoption of advanced value-based payment models in the state. And when I say advanced payment models, I mean specifically the three that you see listed here: hospital global budgets, prospective payment for high volume and high cost specialty care providers, and prospective payment for primary care. Okay, this subcommittee had been created last spring by the Cost Trend Steering Committee. It began meeting in July and met 9 times through March to get to the compact. Compact calls for the adoption of these 3 models. It also calls for the conduct of some studies, including one into hospital costs within the state. There are timelines, accountable parties. It's quite specific, and in fact, I think probably most of you picked it up at the table when you came in today. These are the organizations that have signed the compact. I believe there's an opportunity if others want to do so, they probably could. The compact includes a set of principles that were agreed upon in terms of the desired aims of accelerating adoption of advanced value-based payment, and then lists specific action steps here for the partnering organizations and for the state. Okay. The compact also sets forth a bunch of targets, and this is just some of them, not all of them. Engaging the Center for Medicare and Medicaid Innovation to get Medicare to participate in the models. It's got development of key parameters of a hospital global budget model in about a year. Study of hospital costs and the study of cost shifting. Putting in place sufficient administrative capacity for the state to facilitate and oversee this initiative, and implementation of a hospital global budget model. Okay, there's some other dates in there, but this gives you a sense of what's at the core of the design. The next step is OHIC's going to reconvene the signatories to revisit the compact in about a year, engage progress on the initial year of work, and the compact timeline extends through January of 2026. So that's a little bit of context for the discussion that we're going to have now about value-based payment. I'd like to begin by asking Al and Michelle if you guys would introduce yourselves, and then we'll begin with some discussion.
Sure, I feel a little funny because I can't see you guys on that side of the room, so I might just stand up and And first of all, I want to thank everybody on the steering committee for sticking with this work for all this time and getting this compact signed. I think it's a noteworthy accomplishment. And also, thank you for sticking with us because we've been in here for 2 hours and 15 minutes. Al Caros, I've been the president of Coastal Medical since 2008, and I've been a senior vice president for primary care and population health at Lifespan for a year now. Been one of the co-chairs of the cost trend steering committee since the outset, which I guess was 2018. So this feels like a nice milestone for all of us to get this compact in place, and so it's a reflective moment for me, and thanks to everybody.
Hi, Michelle Letterberg. I am Executive Vice President at Blue Cross. I'm the Chief Administrative Officer and the Chief Legal Officer. I'm also co-chair. I want to thank Al. He is the kind of senior statesman here. He's the only original standing co-chair. I think I came in late in 2020, and then Patrick shortly after. And so I just want to thank them. They've been really collaborative, and I'm so pleased that we're able to participate and have reached the point, particularly on the value-based payment compact, because I think that to the comments of the panel earlier is really what's going to drive the change.
Thank you. And Patrick, I'm going to pass on your introduction. I think you're well established here at this point in this meeting. So I'm going to ask the panelists a series of questions, and then at the end I'm going to open up for all of you to ask any questions that you might have. So Patrick, can you begin by sharing your thoughts on why accelerating the adoption of advanced value-based payment is important for advancing affordability in Rhode Island?
Sure, Michael, and thanks for the question. I think I'll start by first of all, saying thank you. And many of the people are in this room who are signatories to that compact, and I think much like the original cost trend steering committee compact that we discussed earlier, that set the cost growth target and made a shared commitment, a public commitment, a commitment that's shared by a wide array of stakeholders in the healthcare system, and one that's quantifiable. I think in that same tradition, the work around developing this over almost a year, and then again, getting the support, the voluntary shared support of government, of the provider community, of the payer community, for what I think is really, truly an opportunity for transformational change. I would say why I believe it has the ability to have transformational change in terms of moving to advanced value-based payment here in the state is really fundamentally grounded in, I think, what we all acknowledge, that, and has been well established, I think, in literature, not only about Rhode Island, but more broadly in the United States healthcare system, the fee-for-service system does not give us the outcomes that we want, fundamentally. And the cost is what we're focused on and have been focused on and need to be here. But we also, as we've heard today, need to think more broadly. And the fee-for-service system also, to Al's point about the quadruple aim, it doesn't support that either. And so what this document does is set out a defined pathway with clear milestones, clear timeframes, clear steps for us all to take together, and engage certainly with the governor, with the General Assembly as we move forward to actually make that transformational change in how we pay for healthcare in Rhode Island so that we can achieve the quadruple aim and have better affordability as a part of that. So I really believe it's not only the substance that I believe can have and will have an impact on what we're doing to achieve the cost growth target and those broader critical outcomes, but it's also because I think that we have the right process in place. We have the right folks at the table taking this seriously. I think everybody recognizes the seriousness of intent, but at the same time, the hard work is really in front of us. And I think that the time frame, we had some discussion over what the right time frame is, and you saw the document fundamentally really sets out a process at the highest level from now through January 1st of 2026. In my mind, for the level of change that we are talking about, that's a realistic time frame. It's also an aggressive one, which I think is the right balance. It gives us enough time to do this work well, take it seriously, and actually have a real chance at achieving that kind of transformation in how healthcare is paid for, but it also recognizes the urgency behind achieving the outcomes and getting better equity, better access, and better cost growth over time. So that's fundamentally how I think of it, Michael.
Thanks, Patrick. Michelle, can you talk about what the strategies in the compact mean for payers?
Sure. I think, Blue Cross has been focused on value-based payment for a while. We've been working with some providers, but not all providers have been willing and ready, really, fundamentally. And I think the compact creates the foundation that's going to facilitate movement to the next step. The principles in the compact are consistent with where we've been headed. It's really important to have it memorialized and agreed to. It was heavily negotiated. As Patrick, you mentioned, I think everybody who signed on has really bought into this work, which is critically important. I think, as Patrick, you just mentioned, fee-for-service, we know, just doesn't work. And so it's expensive, and it doesn't incentivize efficient and effective care. And so we're totally supportive of using financial incentives to improve experience, quality, outcomes, and address health equity. I think the benefit of the compact is it really gives a level of flexibility. It recognizes it's not all one size fits all, and there's an opportunity to work with payers where they're at over time on different types of arrangements. I think it's really also helpful to recognize that primary care, the importance of a really robust primary care is going to be an important foundation, and that we also have to figure out a way to integrate specialty care providers, which really hasn't happened too much to date. And so we're really pleased that it's there. I think it really will facilitate work moving forward and kind of recognize where different providers are at in this process.
Thanks, Michelle. Al, one of the 3 payment models in the compact is a hospital global budget. It's a profoundly different payment model than what we have in place today. So I'm interested in your thoughts on how this will change the business model for hospitals.
Sure, thanks. I'm gonna do the Jack in the Box thing again here and pop up for that side of the room. This is going to have a bunch of different impacts, and it's interesting that we're making this change in this moment in time, because I think that this is a time when hospital budgeting has been extreme. The revenue and cost numbers for hospitals have been so volatile, and the workforce depletion and the increased cost for contract labor, the COVID-related costs, the really marked reductions in the ability to offer preference-sensitive kinds of surgical treatments. So it's really, one of the things that'll happen is that hospitals will at least have a more predictable revenue stream if we can get on global budgets. The sort of fundamental thing we're going for here is to change the incentives, right? And it will be interesting to see how that plays out if we can get this to come to pass and if we can design it correctly. And certainly the devil will be in the details, and the rates that we set will be crucially important as our systems recover in sort of the short to intermediate term from the beating that we've all gotten here during the pandemic. Notwithstanding the federal subsidies, this is not like a net windfall. This is a struggle and a financial crisis for hospital systems. So we have to sort of recover from that. We have to get these models in place. But when they're in place, what they should do, as somebody who practiced for 20 years, I think a global budget should take away an element of distraction. There just won't be that same pressure to produce volume constantly and to sweat the charges and the collections and the revenue every month. Al's nodding his head yes, and that makes me feel good and you've been warning me, Al, because this is a game changer. You've been warning me for years that ACO models are just nibbling around the edges, and it doesn't take that much to negate what we've been able to accomplish in managing total cost of care. And it was a perfect example earlier. It's kind of heartbreaking to look at what pharmaceutical pricing has done to total cost of care, and it's just like an unrelenting train that's sort of running over a lot of other pieces of work that have been sort of painstakingly constructed and executed. That's a little dramatic. Maybe I'll slow it down now. But you know, I mean, I was watching the reaction shots, Noah, when the conversation came around to some of this, the pharmaceutical pricing, and you're just sitting there going like this, and I'm like, you can tell the people whose day jobs are to manage total cost of care in this room, because it's a frustrating and you know, challenging perspective. But if we get to hospital global budgets, it should really be a game changer. We have been educated by the folks from Maryland on a lot of the nuances that we have to be mindful of, and I think one of the essential principles will be mid-course corrections. So if we lock this in too hard and we can't adjust to what we're seeing, and we have unintended consequences in either direction as far as the financial well-being of hospitals, we're going to regret that too. So, you know, the comment that you made earlier, Patrick, about balance was highly resonant to me as we approach something this fundamental in this really volatile time, and in this setting of where we have to also rebalance public and private reimbursement, as well as sort of look to the competition around us. There are just a myriad of nuances in the public interest that we have to address. But you know, the good thing is that this is a remarkable coalition of people now that have been working together, you know, in this room on this steering committee for a really long time. And if I think that gives us the best shot at trying to take note of all these competing interests and healthy tensions, and hopefully get to a rational outcome that really is in the public interest.
Thank you, Al. One of the other payment models that's highlighted in the compact is prospective payment for specialty physician services for specialists who are not hospital employed. Are there any people in the room who are either practicing specialty physicians or employed by a specialty physician group? Okay, so Patrick, that's my lead into the question for you. So specialist physicians have not been involved in the dialogue, and I'm interested in your thoughts on how do we make them part of the dialogue.
Sure. Thanks for the really easy question, Michael. I really appreciate it. So no, but in seriousness, this is, as you said, it's another payment model along with hospital global budgets and primary care capitation that we've made a collective commitment to pursue and ultimately implement in the compact, and we have to take it as seriously as we're taking the other steps. And so the two things that occur to me is, one, we have to, as we've done overall in terms of acknowledging the challenges and the barriers we are going to have to collectively overcome to make this work successful, we have to do that specifically here and say there have been many prior attempts to try to do this, to try to engage specialty physician groups and specialty physicians in payment reform, and they just transparently have not been successful. So I think we have to ask ourselves as starting places, what are we going to do differently? And to me, something that a lesson for me, sort of an interim lesson, an ongoing lesson, as we've been going around and really trying to talk with a wide array of stakeholders about this cost trends work as a whole, a lesson from doing that I think is applicable to engaging specialty physicians is this. I think we have to really, it's going to take the collective efforts of the different kinds of stakeholder groups at the table. It can't just be government engaging them. It can't just be payers trying to negotiate with them individually. We've got to sit together as consumer advocates, as employer groups and advocates, as payers, providers, and government, and engage them in that collective way. Because I have found as we've done that and we actually demonstrate the shared commitment to this, that gives us just frankly a much better chance of being persuasive. So I think that's something that's not magic, but I think it can be very meaningful, and I don't think it has been tried before in that exact way. And then the second thing that I think is connected with that, but distinct from it, is as we embark on this process and we start to make the changes and we start to hit the interim milestones that we've set out for ourselves, I think the momentum piece, again, I think Al Charbonneau talked about this on his experience in the hospital side. When people see that the train is leaving the station, that we are actually making change, that this is for real, that we are going to overcome those hard barriers, I think that also is the progress. Again, it's not magic. It won't be a necessary conclusion, but again, it raises the probability to say the system is changing foundationally to achieve better outcomes. We need you to be a part of that. I think, again, both of those things, I think, give us a better chance, but it's going to have to be an all hands on deck approach, because this is an area that it's been very, very challenging, and we have to own that.
Thanks, Patrick. Sorry for setting you up with a difficult question. Michelle, now, Your organizations have both been involved in value-based payment in different forms for quite a while. What are the lessons that you've learned, and what's the compelling case to do something different and beyond what we've been doing so far? And Michelle, I'll start with you.
Sure. So I think somebody just referred to nibbling around the edges, and I think that's what we've been doing up to now. I think, we have about 60% of our members who are associated with a primary care physician who's in something we call a system of care with some sort of value-based payment arrangement, but that has not changed cost growth over time, nor has it really improved quality. And so I think, we have to do something different. I think the reference was earlier to aligned financial incentives and changing risk and really focusing and incenting improved outcomes, improved patient experience will really, I think, is what's important to make the change, because without that, it's going to be same old, and absolutely moving away. Even in these value-based risk payment arrangements, they were mostly fee-for-service. And so we have to really move away from those to these much more risk-based arrangements with aligned financial incentives. I think there's enough money in the system. It's just constructing it differently. And I think another recognition for us and as some accountability that we bear is making sure that the provider organizations we're asking to take the risk, we also have some financial responsibility to make sure that they have the capabilities that they need to take the risk, because otherwise we set everybody up for failure, and that's not good for anybody. It's not good for the delivery system. It's certainly not good for their patients, our employees who are getting services. And so, the importance of having sophisticated data and analytics, being able to understand the health of your population, training the workforce differently. I think it's a different type of team-based care. I know Coastal has been focused on that for some time, but I don't think not everybody's had the financial resources. And so I think that's also a big piece of it.
Thanks. Al, what are your thoughts?
So I'm sorry, it looks like Chris Kohler's not here anymore, because I'd love to give him a shout out for the fact of the impact of the investment in primary care in this state that's been ongoing for more than a decade now, because I think that's one of the lessons of our shared experience here in Rhode Island, is that investment can be put to good use. It can help develop systems of care, a systematic approach to care, a team-based approach to care, new clinical programs and administrative supports for primary care offices, which in any healthcare delivery system are still going to be foundational. And so I do think that significant progress has been made. My understanding is that the folks who actually published the last paper in Health Affairs about the trajectory of cost in Rhode Island are looking at possibly doing it again. I think that would be really interesting, because I think what we've learned too is that these kinds of investments take time to really sort of show return on investment. It's not measured in 1 year or 2 years or 3 years. It's longer than that. But now that investment driven by the affordability standards has been going on for more than a decade. I would be really curious to see data that tells us how far that has taken us. But I would absolutely agree that we have to sort of, at this point, it's the right time for us to double down on payment reform, because we have learned too that incentives matter. They definitely change provider behavior, and we know that our systems here in Rhode Island are still too fragmented. Everybody, for any of you who've either had an illness or have somebody close to you who's had to manage a chronic illness, and you've been the one called on to help them work through the system, you know it's still not easy. And even if you play inside baseball like everybody in this room, it's sometimes hard to get things done, right? So we do not yet have a seamless patient experience of care across the different sites of our healthcare delivery system. I think that's another reflection we can make as we look back on our shared experience here, is that we haven't fixed that yet. And so, at Coastal, one of the things that I learned is that you have to invest and build programming. And then there's an 18 or 24 month or longer period of time before you really sort of see the fruit of that investment and and the benefit to outcomes and patient experience. But if I look back to 2011, when at Coastal we were sort of contemplating the fundamental change of embracing accountable care or not, and I look at the way we delivered care then, what we can do today for patients is we couldn't even imagine then. The number of team-based programs, the use of technology, the meeting patients where they are, trying to interact with patients when they actually need us instead of when it's just convenient for them to come to the office. So there is much promise here, and we have learned a lot, but I don't know, we're a third of the way down the road. And when friends and relatives aren't asking you if you know somebody that you can call to help them out to get something done, when that's not happening anymore, that'll be a pretty good measure of how far we've come.
Patrick, it takes a lot of work to get people to agree to sign a compact, but there's always a danger with written voluntary agreements like this that people sign it and then they go back to living their lives and their professional lives the way they were before. So what's it going to take to make this compact an actual facilitator of change and to see those targets realized?
Yeah, so I think first I'd note a really important difference, I think, to this and not to all other documents of its kind, but to many, is it's not only a statement of the aspirational principles, although it is that, and that's really important. It also has clear milestones and accountabilities built into it, and it's public. So it's public, shared, and it's accountable. And so we will be able to know, it will be very clear if we are hitting the standards, hitting the, and not just, again, not just end milestones. By X date, we will have achieved that. It has interim milestones, again, that we've publicly all collectively committed to. So we will know if we have hit those, both in the interim and overall. So I think the level of public transparency and frankly specificity in the steps along the way to achieve the change, I think one, that's a demonstration of the seriousness of the document, that it was not intended, and actually, you know, as Al, Michelle, and I were leading this work and with the members of the subcommittee, they were all really clear. None of us were interested in doing exactly what you were referring to, Michael, of having a document that we put on a shelf and it goes where many documents of that kind have done. We want it to be a living document that actually guides and frames the work that we're going to do. And I think so. I think the very nature of it gives it the potential to be different. We still have to walk down the path to your point, but I think the specificity of it and the milestones and the accountabilities built into it do give it the best possible chance as a starting place. And the second piece that I would say that also relates to how this whole context for the Rhode Island Healthcare Cost Trend Steering Committee work, you know, certainly myself in government, my colleagues here today from EOHS, I see members of the General Assembly, the Attorney General's office. Government has a foundational role to play in this. And there's certainly a role, those of you that know me and my philosophy of regulation, I am not afraid, and there's an important role that regulatory requirements play. But there is also an outer limit of what law and regulation can do by itself. And so why I mention that is this is a consensus-driven process, and we are not going to be successful unless the implementation also has the true buy-in of the people doing the work every day and the people affected by it. So that's, again, consumers, employers, providers, and payers, along with government. We have to do that. And so to me, the fact that we're doing the work in that way, again, makes it real. I fundamentally believe that if we were doing this in isolation in government, we would not achieve the actual outcome. Sometimes you can, certainly, and we should, and we do, and Al mentioned things like, although there was support for those as well, things like the affordability standards, those have been mandates, they need to be, and they've had a positive impact. But I think we've also recognized the limits of those, and that we need to build on top of that additional work, and that's what this work really represents in my mind.
Al, how do we advance these payment models in a manner that's going to improve health equity and not actually create more inequity?
So I guess I would start with a basic IHI tenet, which is if you want to improve something, you have to start measuring it. And one of the good examples that is coming out of the accountable entity work is that now we're cutting all of our quality metrics, we're cutting them by race, ethnicity, and language data for the first time. And that creates a level of accountability that we just have not had before, right? And awareness. I mean, we all want to do the right thing. We want to be accountable. But So I think if we systematically bake this into our program design, that's where we're going to get ahead. I think, also it's already other work that's underway in the accountable entity program by its very design is to connect provider entities with community-based organizations that can help patients address their challenges with social determinants of health. And so we already have sort of some foundational elements, but I think as we design this next phase of a value-based payment, and as we continue the work of the cost trend steering committee with a focus on a broader set of analytics, and as we think too about the aligned work of the convening by the Rhode Island Foundation for long-term health planning, I think measurement, reporting, discussion, collaboration, best practice sharing is kind of how we're going to get ahead. If I look back beyond a few years, I don't think that social determinants and equity considerations were on our radar screen the same way they are today. I think 2-3 years from now, if we can say we're twice as focused as we are in this moment, that's the kind of place we'd want to get to.
Thanks. Michelle, if you had a Blue Cross member who read a news story about this meeting, say, why is this good for me, what would you tell them?
I think it's twofold. I think there was some of the discussion on the earlier panel, right? It's costs. It's the cost of the premium that you have to pay for. It's the cost sharing that you have for services, and that's a piece of it. But I think the other thing is experience, right? I think right now it's not necessarily people go. It's not a great experience. There's not a good coordination of care. We were just talking about that. And so I think particularly if you have a health condition, if you have diabetes, if you have, some other hypertension, having a team-based experience where you're looking at the whole person, where you're providing them access to services, where you're getting nutritional counseling, there's a pharmacist who's looking at your medication, where you have more tools and you're getting more educated to help keep you healthy and manage your care. I mean, that is, at the end of the day, that improved experience. It should feel different, and I think that will help get momentum as well. In addition, obviously, that I'm not minimizing at all the cost aspect. That's important too, but that's going to be a longer-term change, I think.
Thanks. Patrick, I can envision that perhaps a year from now we'll be reporting on 2021 trend in a meeting like this one. What do you hope you would be able to tell a group like this about what we've accomplished towards the compact's ends a year from now?
Yeah, I think most foundationally, it does go back to what we talked about earlier, which is, have we completed all the interim steps that we outlined in that time period for the advanced to value-based payment? Are we on track, to achieve the change that we believe are going to meet the outcomes? And I think ultimately, Michael, the way I think I measure success of this work, yes, fundamentally, it really goes back to many things Michelle just said and Al said as well, which is, yes, we have to make sure that we've achieved the cost growth target. That's absolutely our central measure, and it's really important to have that single measure that we're all looking to that focuses us, and it should. We have to look at the impact and see moderated premium growth over time in terms of the direct impact on consumers and on employers. But also, as Sam mentioned earlier, I do think as we broaden the scope of the work, because we do believe that advanced value payment can and should support these things, have we over time been able to move those core public health metrics that I think, and ultimately, do people see in their patient experience of care something different? So I think ultimately over the next few years, we should be able to point directly to achievements and improvements in all of those areas. That's how we'll know that we've done our job.
Al, when all the good people at this meeting go back to work and they're asked, so what do they talk about at the meeting? What do you hope they're going to tell their colleagues about this value-based payment conversation?
Well, I hope they'll say, in spite of the challenges of the pandemic, which were discussed at some length here, that people are ultimately optimistic, and that as a community we're ready to take a shot at this work. you know, I think there's another, when we talk about equity and the public health outcomes, I think the other thing that we should be thinking about and talking about, and I'll just make mention of it here because I hope when people go back to work they'll make mention of this issue too, which is that if we think about risk scoring and building actuarially sound budgets for total cost of care of segments of populations, if we could start risk scoring for social determinants, and I don't know exactly how to do that, but there are models out there, and whether it's geocoding on zip codes, whether it's looking at kids with a constellation of identifiable needs or risk factors, but to risk score either adults or particularly vulnerable children just based on their constellation of medical diagnoses really kind of misses the point. And if we want to execute properly on whether it be global capitation, global hospital budgets, whatever, I think that we have to get some pretty arcane expert actuarial advice to be able to build the budget models so we can deliver the kind of care we need to deliver to these identifiable special needs individuals. And I think that if we were able to do that, some of those, we could get some movement on some of those core public health measures. And I think because if we can build those models and we can put that funding in place, then we put in tandem with that, we build in accountability for delivering on those performance on those kind of measures. So I hope that idea that we have enough collective experience now that we could be more thoughtful in designing these payment models, and that the public interest got a lot of airtime today, and that we would make sure and maintain that focus as we, crunch numbers for unbearably long meetings that are very high in number, because it'll take that kind of work, and you probably know better than any of us, Michael, but that's what I would aspire to and hope that people would take away.
Great, thanks. Why don't we open up for some questions now from the group? Yes.
Yes, I was wondering about how you build prevention into your model so that if there is an ROI that you could develop around avoided costs for prevention, that's part of this whole equation, because unless you're looking towards the future of how you can avoid costs by doing things better, if you're looking at the value, I haven't heard anything yet that looks at what that ROI is and the investment in prevention through this model.
Okay. I'll say something briefly, Richard. Thank you for the question, and I'll actually ask if particularly Al and Michelle have thoughts on this as well. I would say that I think that's one of the many things that I think advanced value-based payment can enable at the provider level. Because again, if you get out of the business of paying for just simply the volume of services provided, that gives providers the flexibility and the incentive to actually focus on things like prevention. Whereas today, that's in a predominantly fee-for-service system, that's not always the case. But I really would be deferential to Al, Michelle, and others who have actually negotiated and again, in Al's case, practiced and led in these kinds of arrangements. So I don't know if you guys have any additional thoughts.
Yeah, I totally agree. I think it's when you're paid on a global budget or on a capitated basis, then there's some incentive, not just to kind of pull the lever, but to provide care that may be less expensive, but that helps keep people healthy over time, and focus your time on the people who are sicker and need the care at that point in time.
So the investments today may be more expensive, but in the long term, they'll reduce your costs, and that's okay.
Yeah, and what I would say, Richard, that it's really important that there you go. There we are. I think it's really important, Richard, that these payment models, again, in some ways, the current payment system penalizes providers when they want to actually do that. And so we want a system that not just is neutral, but actually encourages and supports that. So if a provider decides to spend time on doing something that they can't, that there isn't a billing code for, but is going to keep that person healthy under a true, well-structured, properly budgeted, and actuarially sound budget model, they can do that and face no financial negative impact, and in fact, be financially rewarded for keeping that patient healthy. And that's the system that we should have.
It's sort of interesting to think about prevention because the time frame is so variable. You know, if you provide the right kind of access to urgent primary care on a Friday evening, maybe you just prevented a hospital admission that was going to happen 24 hours later. If you are working, if you have people with cloud-based glucometers who are sending you their sugars and you're reacting to those in real time, then maybe you're preventing something that would happen a week later. You know, if you're, and then other types of interventions will prevent something that happened 3 months later, and then you're working on childhood obesity, and what's the time frame of return on investment on that? So it gets a little bit tricky, but that's where sort of, you know, the public interest comes in, and how much can we really spend on long-term investment. But there's a whole continuum, and I think you can even quantitate some of the immediate and short to intermediate term kind of return on investment, and there's definitely been a lot of work that we and others are doing on that. But the really long-term stuff, I'm looking at Pat and she's looking at me, because it's like investing in the health of kids so that they'll be healthy older children, healthier teenagers, healthier adults. That payoff takes a really long time, but if we don't invest in that as a state, then we pay the price. So that's an interesting question. I don't really have the answer to that one, but just thought I'd frame out that timing piece because I think it's relevant.
Well, you know, you're developing a model, so it seems like if you can develop a way to quantify what those benefits are as part of your model and put that into your cost equation, you'll be better off in the long run, so that you're not lost in this continual hamster on the wheel without really breaking free of that and creating a model that looks at what are the benefits for making those larger investments.
Michael, you want to break the glass and become a panelist for a minute? Tell us how other states are thinking about that question.
People who invest in prevention, long-term prevention, invest in kids, they do it because it's the right thing to do and not because they're going to see an ROI anytime soon. Because there isn't. Is there a benefit to families and to society? Yes. But there is no short-term financial return under any economic modeling.
And that's why I think that this work being nested, no one should come away from this conversation thinking that we think that moving to advanced value-based payment is a substitute for those kinds of broad public investments as well, right? Of course we need those, and that goes far beyond healthcare, of course. We need those. The state, I think, is looking at making many of those and has the ability to, and that's critically important. So we think this work can be transformative in the healthcare system, can make a real difference in outcomes, but of course, there are, as Michael said, there are broader public investments that are necessary and need to happen in order to achieve the ultimate outcomes socially that we want. So it hasn't been something that the subcommittee or the steering committee has contemplated formally to date. I can tell you in other conversations that we've been having, particularly within the CTC Rhode Island program, that has been something we've been acknowledging as a changing part of the landscape, both here in Rhode Island and otherwise. So I think it is something we're gonna have to think about, because you don't want any significant part of our delivery system left out of the conversation. But in transparency, Elena, it's not something that we have expressly contemplated in this work to date, but I think we will need to as we go forward.
Jeb?
I was so glad to hear you guys talk about the importance of team-based care and the lack of coordination. We're all piling on to fee-for-service, but I think one of the primary evils of fee-for-service is the episodic viewpoint and the silos that it creates. And these transitions create a real opportunity to encourage more coordination in team-based care, but it doesn't necessarily make it so. So I wonder if you have any thoughts, maybe I'll direct it to Al, on how these transitions
I mean, it's the right thing to do, and it transforms the experience for the patient or the member, depending on what your perspective is. But in sort of cold, hard economic terms, if you're on a prospective payment model, then you can think about these investments in folks who, in today's world, different members of the care team that can't bill for their services. You can invest in them, and then you can get the outcomes that you're looking for in terms of reducing your costs. So it is, if it's more cost efficient for a system of care to pay a diabetes management team that might even be made up of an MA and a clinical pharmacist with oversight by a physician, and that reduces the need for emergency care or inpatient care, which you're going to get paid for now under a global budget, whether somebody uses that care or not. There's actually a pretty strong economic argument, I would think, but again, we haven't lived this life yet, but that's the theory, and I think it holds water because we're doing a smaller version of that in shared savings. And even in shared savings, we're making it work, although it's a little more of a white knuckle exercise because it's only a percentage, and there's a whole varieties of things about shared savings models that become more difficult over time. But when you're on a global budget, you're incented to do things that are cost effective. In many, many cases, I think that will turn out to be the best thing for patient experience and outcomes, and that's where you sort of get the collective win. But I think that smart money would be to build out these multidisciplinary teams that are not too top heavy but have just enough expert leadership and advice, and then scale them, which is why systems can do things that small individual practices can't, because some of those centralized programming, it's not going to work for a 2-doctor practice, but if you spread that across a larger population, you're more enabled. And when you have scale, the other thing that you can do is you can identify those segments that have special needs, and if in one practice there's only 1 or 2 of those patients, it's hard to serve them as well as if you're in a system and now you've got 75 of such people, and then you can sort of build more resources to serve those individuals in that unique segment.
Okay, I'd like to thank Michelle, Al, and Patrick for this really good panel.
And folks, I just wanted to then just briefly bring us to a close. That will formally end our panels. I'll just say thank you for all for sticking with us, especially for 3 full hours. We're very appreciative of that, but I hope you found today, for me, as invigorating and exciting to hear about all of this, talk about the work we need to do collectively, and I think it's going to require, as we talked about at many points, everyone's sustained engagement to actually achieve greater healthcare affordability here in the state in the context of better health system performance and what that means for patients, consumers, and employers. So thank you all very, very much, and I look forward to working with you all. Thanks so much.